All right, this is the sixth podcast for this PowerPoint. We're going to discuss the difference between cardioversion and defibrillation. With both, we apply large amounts of electricity to the heart through the chest wall to depolarize the heart and allow the SA node to gain control and control the rhythm normally. The difference is cardioversion is synchronized by the device with ventricular depolarization, the QRS complex. Defibrillation is asynchronized. There is no need to synchronize it because when we use defibrillation, there is no organized rhythm to synchronize it with. So on this picture here, there's many different devices that can perform defibrillation and cardioversion. This just happens to be the picture that I found. And on this, you cannot see it because it's a little blurry, but right around the top of the hand wrist area here is a button that says sync. And if you're going to cardivert, you hit that sync button and these dots appear at the top on R waves. That way, when you hit the shock button, the shock will be delivered in synchrony with the R wave. For defibrillation, we do not need the sync button. We just charge and shock. So this is a strip of somebody being cardioverted. On the top is cardioverted. This patient was in an AFib. And when you deliver electricity on the strip, you will see this straight line and a drop. So this patient's in rapid AFib. They cardiovert. And then once everything straightens out here, the patient's in sinus rhythm. This, however, is VFib, so this was defibrillated. This had an organized rhythm with an R wave to synchronize to, whereas this doesn't. So this patient was defibrillated. They had VFib during a PCI. Once again, you see the straight line drop, and then when the rhythm comes back and is reset, it's normal sinus rhythm. The patch placements are placed so that the electricity can be delivered through the heart. Once again, another picture, you might be able to see the buttons a little bit better. If you zoom in, you can see we have an energy select to select the energy that we want to shock with. We have a charge, so we can charge the device. This is our sync button, and then this is our shock button. I talked about the AED. You are all trained how to use the AED in your CPR class. And then we're going to talk a little bit about ICDs, implantable cardioverter defibrillators. Small device that looks like a pacemaker placed in the same place as you would find a pacemaker. And like I said before when we were talking about pacemakers, if a patient's getting an ICD, it's most likely going to be a combination device, pacemaker and ICD. They really have gotten away from just placing plain ICDs anymore. But anyway, it's placed in the same area and has leads just like a pacemaker. So what this can do is it can recognize VTach or VFib and deliver electrical shocks to shock the patient out of it. So what are some indications? A prior episode of sudden cardiac death if they survived, prior episodes of VTach or VFib, a previous MI which puts them at increased risk for sudden cardiac death, hypertrophic cardiomyopathy, or an ejection fraction less than 30%. Now, sometimes insurance takes a while to approve the implantation of this device. So patients will be sent home with what we call a life vest. And it's a vest the patient wears, and it does the same thing. It has the ability to recognize a lethal rhythm and shock the patient out of it. This procedure is performed the same way as inserting a pacemaker. They are taken to the electrophysiology lab inside the cath lab, where the electrophysiology cardiologist will implant it. Care is the same as a patient that's had a permanent pacemaker. I'm not going to go through all of that again. The generator can be deactivated or activated by holding a magnet over it for a few minutes. So if the patient is going to the OR for a surgical procedure, they need to have their ICD deactivated. There are magnets on refrigerators in the nursing stations, in their med rooms. They're not for decoration. They're for deactivating ICDs and pacers. Then when the patient comes out of the operating room, their ICD can be reactivated by holding the magnet over it again, but really should be interrogated by a rep to make sure that the settings that are supposed to be on it came back as they were previously set. There is a big psychological impact on these patients. They've done some research about quality of life and the psychological adjustment, and they found that patients live with significant anxiety or depression. They need a lot of teaching, they need a support system. They have anxiety because of not knowing when they'll be shocked. Some patients are able to recognize a feeling of when they do have this rhythm, that they can immediately sit or lie down because they know that they're going to get shocked. And some patients, it happens to them in their sleep. So you can imagine what kind of anxiety that produces. So the next two rhythms I'm going to discuss, I'm not going to test you about, but you need to know about them. The first one is pulseless electrical activity, or PEA. Basically, it is what its name says it is. There's electrical activity, but there's no mechanical. So everything looks normal, but there's nothing mechanically going on. The patient is in cardiac arrest. So this is why you need to check on your patients, and you can't solely rely on monitor techs. You could monitor a patient that had a rhythm all night looking all nice and neat like this, and they could be dead. So you have to check on your patients. Relying on a monitor tech is not a prudent thing to do. They are not physically able to go into the room and check on the patient. From their viewpoint, it looks fine. So the patient needs CPR, and according to our ACLS algorithm, we need to figure out the cause and treat the cause. Once we treat the cause, we usually can get mechanical activity to happen with the electrical. It could be hypovolemia, hypothermia, hypoxia, acidosis, metabolic acidosis, hyper or hypokalemia, a drug overdose, cardiac tamponade, tension pneumo, or an MI or PE. And then we have asystole. And before we assume that our patient is totally asystolic, we need to go in and check and make sure all their leads are connected to their chest. Because if one comes off, it could look like they're asystolic. And I know on TV, you'll see them shocking this. This is not a shockable rhythm. You do not shock asystole. There's no activity there to shock. It's total ventricular standstill. Patient needs CPR, needs our algorithm of medications, epinephrine, etc. to give. However, once you find someone in asystole, the prognosis is very poor. Usually there is no resuscitating someone that is in asystole. A little bit about therapeutic hypothermia, just to let you know, it's done after the return of spontaneous circulation, or ROSC. Eligibility, I need to change this because I just was at an education center session last week, actually, and got some updates on eligibility and contraindications. But it's a witnessed arrest with no pre-arrest cognitive impairment, meaning that they had not had a previous neurological event that impaired them. Contraindications is an unwitnessed arrest that has been worked for greater than an hour. They will do therapeutic hypothermia for an unwitnessed arrest if the resuscitation efforts were less than an hour. And of course, if a patient's a DNR, they don't want to be resuscitated. But basically, it involves cooling the body and slowing down the metabolism. And you can see the device and the and how it's attached to the body. It goes around the core and the thighs. And we want to reduce the body temperature as quickly as possible, but we need to prevent shivering, because shivering increases oxygen demands, increases body temperature, therefore undoing what we're trying to do. Why do we do therapeutic hypothermia? Because research has shown that we have good neurologic outcomes and reduce mortality post-arrest if we do this. It slows O2 demands, slows metabolism, reduces cell injury, and kind of preserves the body. There's always been a saying, you're not dead until you're warm and dead. If you're cold and dead, you're not dead yet, because the cold preserves the body. We use that device, we cool the patient quickly. Sometimes we will add ice packs. We want to target them for between 32 and 34 degrees for 24 hours and then slowly rewarm. They're going to need some type of core monitoring for their temperature, whether it's a Foley catheter temp, rectal temp, or a pulmonary artery catheter. They're going to need full cardiopulmonary support. This patient is going to be continually monitored, mechanical ventilator, central line, vasopressors if needed, and sedation, and possibly being paralyzed with neuromuscular blockers if they have shivering. I will not test you about therapeutic hyperthermia, but I want you to know about it because it is commonly used, not only for post-arrest patients, but also for neurological patients. So those of you who go to the neuro ICU will probably see patients getting therapeutic hypothermia. And just a little humor with my cartoon. So this is the end of the podcast for dysrhythmias. We will hit the highlights and practice some more in our class session.